Welcome to episode 221, Recognizing the Impact of Cultural Narratives on Clinical Approaches to Pain and Suffering, featuring Shanda Sugg, licensed professional counselor. Make sure to subscribe to be alerted about future episodes by Clearly Clinical. Learn, grow, shine. Hello to our listeners. My name is Beth Irias, and I am so excited to have my dear colleague and friend, Shanda Sugg, back today to talk with us about pain and our relationship to pain and all the things around us that may influence. Shanda, it is lovely to have you back and see you again.
It is so good to be with you again, Beth.
So for our listeners who are not familiar with Shanda, she is a licensed professional counselor, and one of her specializations is trauma. And I will let her take it from there. And please tell our listeners a little bit about yourself.
Yeah, absolutely. So I've come to identify myself as a soul hugger. The work that I do, I am a licensed professional counselor. I am a liberatory coach. I do a lot of training and consulting, but ultimately I try to help people be human with other humans. And that is a lot about introducing people to their nervous systems and helping them realize they have one and that other people have them, and helping people have a different perspective to make sense of the world. So culture influences how we see the world a lot. And so we go, I like that, I don't like that. And helping people reframe that to that feels safe, that doesn't feel safe. There are people, so many personalities, and I'm like, oh, so many nervous systems, right? So whether it's the one-on-one, I do a lot of relationship therapy or coaching. It really is just trying to help people understand how the experiences we've had in our past don't go away. They live in our bodies and they activate our nervous systems, and through an appreciation and understanding of that, helping people to do that deep-rooted healing that allows them the freedom and liberation to make decisions in their relationships in their future.
Fantastic. I am so happy to have you back today. Shanda has joined us previously for a couple of different conversations. One of them, she participated in the panel called Lifting Black Voices, and also in another one about transgenerational, multi-generational trauma and working through that. Shanda, there's so much here to talk about. I know your purpose for coming on today was really talking about how our marinade, if you will, influences our relationship to pain. Where do you think we should start today?
Well, let's just start by talking about pain and the spectrum that it exists on, from discomfort, dissatisfaction, pain that feels noticeable yet tolerable. And then there are those pains that don't feel tolerable. And I believe that our cultural and familial upbringings influence how we are able to identify pain, how we express pain, whether we even know that what we are experiencing is pain, and is it even okay if you do recognize that you're experiencing pain to do something about it? And I think, over the course of history, there have been so many different relationships to pain. I think about surgeries that were performed before anesthesia and anesthetic became something that was readily offered and able to be, there to reduce pain. People were still having, life-altering injuries. And how did those people feel about pain, right? Did they express it? How did they express it? I think about growing up. Pain wasn't something that was talked about a lot, but I did not see people around me expressing a lot of pain. And that could be physical pain. Like, I can recall many times where, like, maybe my mom would have a headache. I would know she would have a headache because maybe I noticed a change in her affect or something. And it's like, are you okay? She says, I have a headache. But there wasn't like this rush to take medication to get rid of it. It just kind of, it'll pass kind of thing. But then there were other people in my life that if they felt even a small bit of discomfort, they were looking for something to alleviate that discomfort, even if it hadn't risen to the point of pain. And so for me, it's not an attempt to, be overgeneralizing different cultures' approach to pain, but to emphasize that we do have them. What are the messages that we received about pain? And as clinicians, what are the messages that those we're supporting and journeying with? What's their relationship to pain? I think without that conversation, our own lens and our own relationship to discomfort and pain as clinicians kind of become the mode in which we go with and travel with the folks that we're working with. And that may not necessarily be helpful to the people that we're with. And so that's really what I wanted to kind of have a conversation about, because once we can understand like that pain, we're talking physical pain, but we're also talking emotional pain, mental anguish, relational pain. And there are so many people who just think that's how it is, that they don't even recognize they're experiencing something that they could receive relief from. And if they don't know that, they're often not bringing it.
Yeah. It just is.
We're not talking about it. We're not, having discourse about it, because they're like, oh, I just thought that's just how my life has been. So that's where, I think that it's important to talk. And really, we'll get to talking about the importance of reflection.
Thank you. Thank you, LaShonda. This topic, as we record this in 2024, pain is a big part of the national medical conversation because of the opiate epidemic and the factors that led it to happen here. That yes, there was what some really bad players were doing behind closed doors in terms of the influence and the access to, say, pain medication. But on the flip side, there were also these kind of cultural norms that have been studied, and we're seeing that this is part of it, that how it happened here was part of the standard American perspectives about pain and suffering, and that they are so different than people in other cultures. Again, generalizing, but can you speak to that a little bit, and how we, as like your average American, may view pain and suffering versus someone who is in another country?
Yeah. And even there's the quote unquote average American, and then breaking that down based on marginalized communities. So I just think, when we think American culture, there is a small window of tolerance that we have for discomfort, pain, and dissatisfaction. And so with the American dream being the pursuit of happiness and the driving motivator to get to a point or status in life where things are all good. I mean, it's a phrase we've even used for decades now, like, it's all good. It's all good.
That's a whole brand. I'm pretty sure that's a brand, right?
I'm sure, right? But let's think about that. It's all good. And when it's not all good, that is a deviation from what we've been sold and what we've been told. And so it's like, how do I take this thing that's not good right now and make it good? And pain doesn't feel good. And so this hyperfixation on minimizing or eliminating pain and discomfort leads us very open to, well, what's going to do it? When we look at addiction, oh my goodness, I really wish I still had it up. I saw, and I want to give credit to whom it's for, but I saw such a great definition of addiction, and I will look for, but it illustrated, this idea that and it's not a direct quote, but our desire to eliminate pain is greater than our capacity to withstand it. And that really is addiction, and why we can be addicted to so many things. Is it going to take the pain away? I think I was in 8th grade, so around 13 or 14 years old, when I learned that like taking a Tylenol didn't fix what was wrong. It just stopped me from knowing I was in pain. And as an adolescent, that was mind-boggling to me. I was like, wait, so whatever reason I'm in pain will still exist. The medicine just blocks me from knowing I'm in pain. And I think at that moment, in subtle ways, I didn't want to just be unaware. There was something about me that's like, I don't want to pretend that I'm not in pain. I actually don't want to be in pain. And I think at that point, I started to view pain as a gift. Now, this does not mean that I'm like, bring it on. It doesn't mean that I don't take medications. I do sometimes. But what it means to me is pain is a signal that is directing my attention to something that needs care. I want to put my asterisk and caveat. I know that there are people who have chronic pain and are continuously feeling pain, and I am not trying to minimize that at all. I know the frustrations for so many people when they are feeling some kind of pain or discomfort and can't get a diagnosis, can't figure out what's wrong. Even if they get a diagnosis that is horrible, there's still a little bit of relief to go, oh, at least I know what it is. That feels like a validation of the experiences that someone is having. Yeah, this sucks, but at least one, it's verified and I can prove that I'm in pain, because I think sometimes our internal pain, and this goes back to, I'm really terrible with names if you can't know that, but some research was done. It's SPOT theory, social physical pain overlap theory, that postulates that social pain is processed in the same part of the brain as physical pain. And it flies directly in the face of sticks and stones may break my bones, but words will never hurt me. And I'm like, lies. I always knew they were lies. It's nice to have some research to back it up. But again, if a person was not allowed to express or demonstrate that they are in physical pain, how much more are they not going to be able to express their own emotional or social pain? And on the other side of that spectrum, if just a little bit of discomfort can make a person feel like they're in excruciating pain, how much more are they going to try to do things to minimize so that it can be all good? And so I think as clinicians, we have a really great opportunity to do some assessment. And I don't necessarily mean paper assessment, I'm sure some exist, but I just mean, is assessing how a person relates to pain part of our process in getting to know the people we're journeying with? And if not, and they're coming to us around painful things, how are we engaging with them in a way that meets their needs best?
As we're talking about this, I'm also thinking about the different individual perceptions of pain. So I'm a highly sensitive person. I have sensory processing sensitivity. I check the boxes of neurodivergent in a number of ways. And what I perceive as pain is definitely different than somebody else. So there's this individual factor. Then there are also, as you were saying, kind of these cultural nuances of like, oh, well, I don't want to complain about it, or, and the example that you gave about, essentially this validates it. I just had that happen with me, that I was in an unbelievable amount of pain. I went to the doctor. They said, I think this is what it is. And the pain just got worse and worse and worse and worse for weeks. And then they finally did some more tests and went, oh, actually, and it ended up being this thing that's like, 10 out of 10 on a pain scale. And I'm going, so that's why I can't sleep and why I'm crying. It was awful. And I totally felt validated when I saw the test results, because I was appreciating that even though I knew I was in pain, I needed like this validation from the establishment.
It's so real.
To make that pain valid.
Having this conversation, I can't help but think about the disparities in maternal death. particularly with African American and Black women being the highest in our country. That research was done, that medical students, I think this was done within the last 10 years, still believe that Black women and Black people don't experience pain the same, therefore how they're treated. And as a person who sits in those intersecting identities, that is so painful for me, to know that there are so many misunderstandings and so many stereotypes and all these things that get embedded into the institutions that are supposed to be providing help and providing all these things, that if I say that I'm in pain, that's looked at differently than if another race counterpart, if you say that you're in pain, right? And so there's that. And it's so interesting that I had a friend who went to the doctor because she was in pain. She ended up, I think she had PCOS and ended up having to have a hysterectomy. But in their asking about her pain level, you know, she had had so many incidents, and she said, well, what's the number you need to hear where you're actually going to take me seriously and give me medication? Right. And one that devastates me still, I'll try not to cry as I tell it. When my husband's mom, my mother-in-law, stage 4 metastasized cancer, it was back, and she had fallen. And so she went to the hospital. I was actually facilitating a training. My family's like, there's nothing you can do right now. It's okay. Just come later when you're done. So finish up the section I had to do when I went to the hospital. She's like in and out of consciousness. And I knew she was in a tremendous amount of pain, because the agreement that we had is that, you know, she actually didn't want to die at home. And she wanted to go to a facility to die. And so she started asking to go to a facility. And so we're sitting here with the reality of this in front of us. And one of my sister-in-laws lives in Africa, and we were on the phone with her. And she asked a question that I had not think to ask, but I thought, why should I have to ask this? But oh my God. And she asked the question, have they given her any pain meds? And I look at the doctor and I said, has she had any medication? And they said no. She had been there for like 12 hours. She was on a litany of medication. She was in hospice. Okay. And so the pain, the anger, the multitude of emotions I felt in that moment, to know that you didn't have to know her personally to know that she was in excruciating pain, and in a hospital, she wasn't given medication, right? Is that the incompetence of the medical staff, or is this the perpetuation of these ideas about Black people and Black women in pain that caused them to have her there for hours upon hours upon hours and never even attempt to satiate her pain? And so looking at the very fragile sense of resilience and endurance that we can sometimes possess as American people when it comes to pain, particularly relative to folks in other countries. There are still these disparities within even the American culture based on a lot of marginalized communities who are treated a certain way around pain, and then even emotional pain. This trope of the strong Black woman, right? This idea that is perpetuated often within our own culture to say, like, we are supposed to be strong. And when we're not strong, we're magic. We say Black girl magic. We're teaching our little girls to be magic and our little boys to be magic. And all of that is outside of the reality that we live in human flesh suits that experience pain, but the expectation that we somehow surpass, you know, the fact that pain exists and that we toughen through it and that we don't cry, we don't show emotion, don't let them know they're getting to you. All of these are messages that make sense to me, particularly when I look at the history of African enslavement on this continent and what the expression of pain could have meant. It could have meant death. It could have meant someone else that you loved was severely beaten or killed. So being able to suppress and hold in that pain and the demonstrations or expressions of that pain has oftentimes meant survival for my ancestors and people like me. And part of the work that I like to do now is realize that we're still navigating a world, but when they come into my office or when they come online with me, what does it feel like for 60 minutes for us to just open that up and be real with it? Not and close it back up before they have to go back out into navigating the world. But if people don't know that there is a such thing as that's painful, how do we alleviate that a little bit? How do you recognize that that thing you've been carrying your whole life, it's heavy and it's not even yours, but your back has adjusted to the weight? So that feels important for me in my work.
Thank you, LaShonda. It reminds me of an interview we did with Joanne Kim, where she was talking about the potential differences in processing of emotion by people who've been marginalized, and also the generational impact that comes into that, as the example you just gave. There are so many layers in this, but if you're looking at it through the lens of attachment theory, if a baby has reason to believe that its cries will not render a response, at a certain point, we find ourselves in the world of learned helplessness. And then what do we do with it? Like, do we not cry? Do we cry and just anticipate that no one's going to hear or that no one's going to respond? And if that gets perpetuated over time, how does anybody cope with physical or emotional pain when we believe that the institutions or the people around us won't do anything about it or even necessarily acknowledge that it's happening?
I believe that we find mechanisms that allow us to release what we're holding in some ways, and then we carry the rest. The child and the baby that realizes their cries won't be heard and acknowledged has a way that they learn to navigate, but so does the child who cries, and not only does the need not get met, but they get chastised for it. They get relationally punished. And so they learn, oh, this relationship is very important to my survival. I can't mess that up. I got to keep it in. As a matter of fact, I might even go a step further and go, forget my needs. How do I attend to yours? So that people-pleasing way of, and sometimes the subconscious way of saying, if I take care of you the way I desire to be taken care of, maybe I can teach you how to take care of me, and maybe you'll reciprocate that. I have a family member, an older family member, who was giving birth to their first child on their 17th birthday and was told by their mother, and you better not be acting a fool up in here like all these other women. So she birthed her first child without cries or screams, like the primitive, animalistic, guttural gifts that we're given to express our pain were taken away from her. I'm watching her body fail in so many ways, internally, organs, and I once I learned that story, I thought of the 55 plus years that she's been holding on to that single moment of pain she didn't get to release, let alone all of the subsequent pain that she's experienced and never felt release for. And to talk to this person, I remember they said to me, how are you feeling and stuff? And they were able to say like, well, I'm always in pain, but I'm managing, I'll get by. And I know that if they take a Tylenol, their pain is probably what I would consider an 8 or 9, because they walk around daily at what I would probably consider a 5 or 6. But emotionally, I've also never really seen this person express a lot of emotional pain. And they found one way to help them cope, and that's been religion. There's been a rationalization and justification that her pain equals righteousness, that she's suffering for the sake of something greater. And I believe that has helped her navigate the journey of her pain. But I don't know that she's ever had the experience of someone saying, oh my God, the daily endurance of this much pain is not the normal experience, the normal human experience. And what can we do to help alleviate that? That shows up in how someone like that parents. That shows up in how someone like that engages with a romantic partner. It impacts how they go to work and what they're willing to do. If my body is intended to feel pain, then working in the capitalistic mill that says, give it all and don't have any for yourself makes sense, right? So that's why I think I think if clinicians are not already, so much of what they're seeing and hearing and engaging with the people they're journeying with would make sense if they understood how that person understands pain.
It makes a lot of sense why anyone eventually, consciously or unconsciously, would distance from extreme pain. As you said earlier, our pain alert system is there to tell us when something needs attention. And that's also typically designed for acute, episodic examples of pain, not weeks upon months upon years of pain and whatever trauma may be occurring, and how the system effectively breaks down. And I appreciate the point that you made about that impact on the community around that person, because their pain management system is completely frayed, completely spent. They have been in overdrive. And then you can see how the cycle could repeat itself.
Absolutely. It reminds me of, and they're like, if you have a newer home, we moved into a new home, and our smoke detector is now like hardwired into something, and we don't have to do anything. But growing up, you had to change the battery, ideally daylight savings time, right? And if the battery was getting low, it would make a beep to let you know it needed to be changed. I can name countless people that I know who either just didn't have the time, couldn't reach it, or just didn't change that battery for a really long period of time. And after a while, you just don't hear the beep. It beeps in regular intervals, and the people who live there who are used to hearing it, because at some point when it first starts happening, the brain is alerting you, hey, that sound is out of the ordinary. You should do something. But if it's going to beep every 3 minutes for 6 weeks, at some point the brain is like, okay, well, clearly we don't need to be alerted by it anymore because it's happening in this interval. And I believe that's what happens to our pain detection system. Like, oh, here's this thing, I should look into that. But when we don't and it continues, well, we start making the adaptations around it to feel less discomfort in some way. If I hurt my ankle and I can't go get it taken care of, well, I might limp, or I might use some kind of assisted device. But minimizing the pain doesn't necessarily address what's happening, and then more damage happens. And I feel like that's what happens with a lot of folks. And this is namely grief. When I talk about this, grief for me is one of those, I love grief. I actually appreciate it. It does not always feel good, but helping people to engage with grief in a different way can really change the quality of life, because every time grief gets activated and all they know how to do is push through it or numb it or ignore it and do these things, it doesn't mean it goes away. They just learned how to adapt around it. But actually helping people to sit in the grief, it changes people's lives. And most of them didn't even know that was a possibility because they never witnessed anyone do that.
I cannot attribute this quote correctly, but I saw a quote that I'm paraphrasing that was effectively, our satisfaction in life is directly correlated to our ability to tolerate uncomfortable emotions. And I've spent a decade turning over this quote and thinking about it. And as you said, generalizing within American culture, we've been sold this idea of do X, Y, and Z, and then you will be happy. and then we'll just stay happy too. Like, not only are we going to get happy, we're going to stay happy. And if we're not, then we're doing something wrong.
It is definitely your fault if you're not always happy.
Like, we need to do something else. Pursuit of happiness. And it pulls from much more ancient and tenured ideals about mindfulness, the presence of mind with pain and the experiencing. And I've had a repeat of a surgery in my life. And the first time I did it without mindfulness in the recovery. And the second time I did it with mindfulness in the recovery. And just speaking for myself, I had an entirely different relationship to the pain. And there were actually more complications the second time around. But my experience of it was different because I felt like I wasn't so frantically trying to get rid of the pain. It was, okay, I notice the pain, and can I notice the other things around it?
Yes. So one, I found the quote that I was looking for. I can only attribute it to the Instagram person who posted it, which was Britt Frank, but is addiction is what happens when our desire to avoid pain outweighs our capacity to endure it. And in some ways I'm like, yes, but also like most of us don't know our capacity to endure it. It is our perceived capacity to endure it. And the thing, like you said, being with it, I remember having a really, 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 really bad flare back in 2021. And it led to all kinds of things happening. And I was, again, trying to fight through it. When I settled into mindfulness and I was just present, I really did realize that there was like only one or two parts of my body that were in pain, and there were a lot more that were not. That perspective really did shift how I was navigating the situation. And I think as clinicians, folks come in with binoculars. And they have these binoculars up to their eyes and they are pointed at one particular situation, relationship, whatever it is magnified by 200. It looks super huge and super up close. And they come in and they want to work through whatever this thing is. And I think often as clinicians, we move into the route of like validating, saying, thank you for telling me, hey, that is a big deal. And we move into helping the person feel a sense of, like you said, you get a diagnosis and you go, yes, thank you for acknowledging how painful this is. It's even sometimes helpful that a person might come in and be like, oh, it's not that big a deal, for us to go, hey, that's a big deal, right? I think that's validation. But I truly believe an under-taught and practiced skill is reflection. The difference between validation and reflection for me is validation is jumping right in where the binoculars are and helping a person to feel a sense of, yeah, you get it about this thing. For me, reflection is helping a person take the binoculars down. It doesn't take away the thing that the binoculars are looking at. It's a real thing. It is impacting you, but it also allows a person to see the other things that are there. And for me, this is important because of even how I define gratitude. When I talk about gratitude, often people think of gratitude as the glass half full. Let's find the silver lining. And for me, I say, for me, that's neither. For me, gratitude is taking the binoculars down. It's going, here is what is. And in what is, there's space for me to have gratitude without completely eliminating the adverse, the pain, the challenges. I don't think there needs to be a numbing or disappearing of those things for us to move within gratitude. And as a clinician, I really look at myself like a mirror. If I were to say, hey, Beth, you have some food in your teeth, you might go to the bathroom, look in the mirror, and you're going to go and look right at your teeth and try to find the thing that's lodged in there. But just because that's what you're focusing on doesn't mean that's all the mirror is reflecting. The mirror is showing everything that's in front of it, including the things in the background that you're not paying attention to. As a clinician, I want to be a mirror that doesn't just hone in and focus on the thing that a person is bringing, but being able to help them see a more whole picture of what is. And sometimes that's perspective, of a perspective other than their own, but oftentimes it's different perspectives of different parts of themselves.
I appreciate the perspective on the difference between validation and reflection. The other place that my mind went to was like the fix-it paradigm, that we as mental health professionals are all called to this profession for a myriad of reasons. And I think foundational for many of us is like, I want to help people. And that any of us can fall into the trap of, well, have you tried? My uncle told me about this treatment. There's a special ice pack, like whatever. And I mean, let's be honest, we all do it. We do it as friends. We do it as family members. We do it as clinicians. How do you see kind of like the fix-it paradigm about pain, which is sampling from the buffet of the happiness narrative in the United States? How do you see that fitting in with the pressure I think clinicians feel when someone's in their office and they're in pain and we're like, I want you to leave in better.
Yes. Well, one, I have to say that from my purview, it is a direct correlation to how we have been conditioned under capitalism. Under capitalism, there's always something to consume. There's always something, and it's always aimed for like a goal of you being better. We're going towards that pursuit of happiness. I think as the system of therapy and counseling are nestled pretty tightly underneath that umbrella, there is this desire for folks to, like you said, make sure someone leaves, quote unquote, better than they arrived. It's almost like we're selling something. I am supposed to be attributing to your pursuit of happiness. And if you can leave smiling, if you came in crying, or if you can at least leave not crying, if you can say, ooh, I feel better, then I think that serves towards the ego. And I mean that as neutrally as possible, but the ego of the clinician to say, okay, good, I did a good job. And that is often when people seek counsel in therapy. When it's gotten to the point where they just need something that's going to alleviate their suffering. So I think that some of the pressure we feel is in the condition that people come into the space with us. And a lot of times their stated intention is, I want to feel better. I am depressed and I don't want to feel it anymore. I am anxious and I don't want to feel it anymore. I am experiencing, my relationship is in turmoil and we don't want to feel this anymore. So I think some of the pressure comes because that's what people are asking for. I feel like that is why consultations before getting into relationship is so important, because in my 30-minute consultation, I get to tell people that very rarely is my perspective of my role to make you feel better. There are going to be times when you're actually going to feel worse when you leave me. And I use the example of, and this is an example I've seen on others because it's not my personal example. I never had braces, but when I grew up with folks who did have braces, whenever they had their orthodontist appointment and I saw them next, they did not feel good. There was a tightening, that would happen and they would seem to be in discomfort. But the notion was it was towards the greater outcome of straightening something or aligning something that wasn't aligned, right? Someone who goes to get a bone reset so that it can heal properly, that's a painful process, I would imagine. But alignment can hurt. And I truly believe that so many of us as clinicians are not necessarily trying to lead people towards the alignment for themselves. That can be a painful process, but trying to wrap things around it to just make it feel better. So I tell people, instead of being that ace bandage that's going to make it feel better, I'm probably more like the doctor that's going to reset the bone. And I need people to know that coming in, because I'm not trying to presume that everyone wants that. But I also feel like if people know ahead of time, and I can talk through why that's my philosophy, I say, I am a root worker, and you're coming to me with a leaf. And we can cut that leaf off, and I think you would feel better for a moment, but another leaf will grow back coming from the same root. I help you get to the root. And if we can heal those roots, one, the leaves will start to die away, because what fed them is going to be changed, and what grows in its place will be something healthier. Is this a journey you're willing to go on? You're still in charge, all the things, but I want people to know this is not to solve it, fix it, eliminate it. We're going to get to know your pain, your shame, your trauma in a way that helps you see the perspective that these emotions, the gifts that they're trying to give you, instead of just eliminating them out of the way. And what I will say is most people say yes, and most people are glad that they are. And my ability to do that is because I've sat with my own. And I think this is a key point. Because I have been intentional and mindful to sit with my shame, my pain, my fear, I no longer have this extreme discomfort with my own emotions. So I don't feel uncomfortable watching someone else experience theirs. And I think for so many clinicians, their relationship to those sometimes challenging emotions shows up when they're with someone they're supporting by way of trying to pull them out of it, so that the clinician doesn't feel uncomfortable, doesn't feel uneasy, doesn't feel like they're not doing their jobs. I want to be honest. I definitely have times when I will sit and be like, was that helpful? Like, not my method, but like someone might leave and I just be like, man, they didn't leave with this big smile on their face. Tons of times they do. They might say, oh, I feel so relaxed. But there are times when people are just like, and that used to be like so hard, because I spent most of my life, 3/4 of it, as a people pleaser. When I realized that if I didn't sit with that with myself, then I was just trying to please every client that I was with. Oh, so as I started to heal that part of me that only knew how to survive by pleasing other people, pleasing my clients is not a top priority for me. Giving them the safety they need to be with the things that they want to get rid of is the gift that I give to them. But I don't bait and switch. I let people know that ahead of time. But that feels so important to me, because sometimes I'm the maybe third or fourth therapist that someone's been with. And when we get to this part, they're like, wait, hold up. I remember you said that in the consultation, but I didn't think you for real meant like, oh, you want me to do what? Give this feeling a color? What does that mean? Like a shape? Where do I feel it in my body? Aren't you supposed to just make it go away? Right? And it's just kind of like, yeah, no. Because if you can sit with it in this moment and not die, the brain tracks that. And it goes, ooh, it wasn't comfortable, but we didn't die.
Number one, I love the analogies that you just gave there about dental braces. You brought back some tough memories for me.
I'm so sorry.
And also what you'd said about you came in with a leaf and I'm a root worker, I think was really powerful. What's occurring to me right now is the influence of concepts like distress tolerance. How do any of us learn to sit with more pain, particularly if we have a fried pain management system?
Yeah, no, that's a good question. And I think titration, right, is helpful. But also to say, can we sit with this pain? That can be foreign language to many people. Like, I'm clearly sitting with the pain because I'm here with you. right? And I think part of that is helping people to recognize how they sit with any emotion and how they recognize anything in their body. So if I ask someone a question about where do you feel that emotion in your body, and sometimes people are like, I have no idea what you're talking about. I say, that's okay. How do you know when you have to go to the bathroom? And it's kind of like they'll look like, well, what do you mean? No, like, you've been doing this for a while. How do you know when you have to go to the bathroom? And it forces them to sit and think, well, how do I know? Well, I usually feel something here. Like, okay, how do you know when it's urine or when it's defecation, like feces? How do you know the difference? And they're like, oh, but you know the difference. So this concept that I'm introducing to you of being able to recognize where you feel certain things in your body, even if a lot of your communication happens in your stomach, there's a process that we can start mapping to differentiate what those things are. So how do you know? I give them something they're already familiar with. How do you know when you're hungry? How do you know when you're tired? How do you know when you're thirsty? I need people to understand that there is a way that they relate to their bodies. And then it's like, okay. And so that moment when you're hungry, but you're not in a particular place where you can eat something right away, how do you respond? You know, oh, I distract myself. Okay, cool. Now that we know that, you're probably using that tactic in other ways. Right. And so some people are like, well, that's why I always keep me at least a little snack in my bag. And I say, that's perfect. So when sadness comes up, when you start to feel those beginning moments of depression or anxious, what's the snack we're going to put in our bag? What is something that can come through your eyes, nose, mouth, skin, or ears, the 5 senses that you're going to keep with you in order to be able to not make it go away, but settle yourself into it. And so I think that titration, so maybe when you're coming in with me for this hour, we're going to go back to the memory. We're going to open that up and we're going to sit with it. And what I mean by sit with it is we're not going to rush to change the conversation. You start talking fast, I'm going to slow you down. I'm going to say, can you pause and take a deep breath? And part where reflection comes in is, you know, validation oftentimes hones in on what's being said. For me, reflection is helping people understand what their bodies are doing. So I will pause, someone is saying something, and yeah, they might start crying when they say a thing. Well, I'm not going to repeat the thing they said. They know what they said. I'm going to pause and say, so I noticed you took a big gulp right when you said this word. Did you notice that? No, I didn't notice that. That's okay. Can you just take a deep breath with that? And I'm wondering what that gulp might have been communicating. Yeah, I'm noticing that your leg is, you know, you're kind of patting your leg up and down, or you're rubbing your knee. Did you notice that? And most people don't notice because we're self-soothing. The body is doing what the body does, but we don't know what it's doing. So I introduce people through reflection to what their body's doing. I noticed your breathing change during this moment. If we can understand that during this, then maybe we can start mapping how it does this in other situations. And when it comes up, what's your default response? Or I normally do this. Okay. So what we're going to do is we're going to practice not doing that for 30 seconds. After 30 seconds, you are free to do what you've always done in order for that feeling to go away. But if we start with just 30 seconds, then you are building your capacity you didn't think you had. The body didn't let you know you had that capacity, so you think you don't have any, but you actually probably have a very large capacity to be with what is. You've just not really had anyone help you do it. So that's how I help people titrate through that together, so that when they're by themselves, you know, it's not just sit forever. Maybe they're going to move it to 60 seconds. And I'm a proponent. Set a timer. Like, you don't have to be a hero. Set that 60-second timer, and sitting with it also means don't hold your breath and try not to think about it. Actually pay attention to the sensations you're feeling in the body. Is your temperature going up or down? Is your mouth dry, or do you feel like you're salivating? And start giving people, are your palms sweating? Things that we have a tendency to overlook is what I'm helping people to hone in on. And once they realize, like, Okay. I did that for 60 seconds. It was not the most pleasurable. It's like a plank to me. You know, a plank 60 seconds lasts so much longer than an average minute. I got better at planking when I was present in the process instead of distracting myself. I started talking to the different muscles that were engaged that I didn't think. When you realize how big your core is, it's not just your stomach, y'all. Your core is so much. So when I started saying words of gratitude in my mind to the different parts of my body I felt engaged, next thing you know, the 60 seconds was up and I was like, oh, look at that. So those are ways that I think we can build people's capacity to be with what is, even the painful stuff.
There was so much there in what you just said. I also appreciate the piece that you had mentioned about our own capacity as a clinician to sit with our own pain or the pain of others and needing to kind of strengthen that muscle. How much do you use psychoeducation, knowing that many people, if not all of us to some degree, have difficulty identifying where we're in pain and being able to describe it to somebody else? What does it look like for you with someone who is over time become largely disconnected from pain as a way to cope with it?
Yeah, absolutely. The question about psychoeducation all the time. What I tell folks is, this is not a restaurant where I bring you a dish and you eat it, but we cook together in the kitchen. Anything I do with a person, I tell them what I'm doing. People have varying degrees of interest. Like some people are like, don't need to know how the sausage is made. Like, don't really care. And I'm like, okay, cool. But I offer, right? And I tell people my job is to work myself out of a job. And if you can understand why we're doing the thing that we do, and it's usually after, right? We go through, they have this experience and say, now let me help you understand what was happening there, because I want you to be able to replicate this when you're not with me. When, you know, I create such a calming environment that people don't necessarily always feel what they feel while they're at work, while they're arguing with their partner, while they're trying to raise their children. And so just to create the experience is one thing, but to create the experience and give them something to take with them. I say everything with me comes with a Ziploc bag. Stick it in there, stick it in the freezer. You ain't got to use it all at once, but you can come back to it. It holds well. And I think for folks who have prioritized, whose bodies have prioritized survival by disconnecting from pain, and the body have also been disconnected from things like joy and pleasure. And so I don't always just start with the painful stuff. Sometimes we got to start with, let's help you recognize when you're feeling anything. Right? Because it's not that you're not feeling it. It goes back to when I was in 8th grade. It's still happening. You just don't know it's happening. Right? So how do we start to recognize when you're feeling anything and just know what it's like to feel something? We don't have to jump right into the deep end. If someone is not coming in that space, that part of that titration is, what does joy feel like? What does contentment feel like? What does what does feeling the breeze literally? And I'm always using the 5 senses, being able to have someone, what do you hear right now? Oh, nothing, but there are so many sounds. And when they slow down and realize that clock has been ticking the whole time, it has. Can you feel the fabric of your shirt on your skin right now? And actually allowing people to slow down and be like, oh my gosh, I can actually feel that. But hey, thank goodness that your brain is filtering out data that's not necessary for the moment, but you still have access to it. So it's really teaching people to dig into some of the toys in their toy box that they haven't played with in a long time. And I find that to be really helpful.
I think your comment about pacing, about taking it at small amounts of time and building it up, I think is a really important one. And on the topic of numbing, what came to mind for me, having worked in acute care addiction medicine for a number of years, the phrase that was constantly in the hallways was, you can't selectively numb. So if you numb away that, then you're numbing away this. And what's it like when all of it starts to bloom? And that was, I can think of whole groups that we had in conversation about that one phrase. thinking about the limited time that we have left, I know I'm processing what you've said and what you've shared today. And this idea about less validation, and not that we shouldn't do it, but more this idea of reflection and being able to see, as you said, everything in the mirror in addition to the spinach that's in your teeth. This may be very different for clients because like I didn't come to you about that mark I have on my knee. I'm here about this thing in my teeth. So why are we talking about the mark that's on my knee or that my hair looks fabulous today? How do you answer that question? Because it can feel like almost like a bait and switch where it's like, I know you came for that, but we're actually going to go over here.
Yeah. And so I'll reiterate why the consultation is important. I'm very transparent with the folks I'm working with. But for someone who's looking to try this out, like with the example you gave, I'm like, well, the mark on the knee is where they fell and bumped it. And the thing that's in their teeth is because their head went down into the ground, right? It's connected. Like I had this whole elaborate, oh, that's where you fell, right? And for so many people, I mean, countless times, someone will come in and be like, here's what I want to talk about. And through this process, we end up somewhere way over there. And they're like, that is not what I thought we were going to be addressing today. But I see how they're connected. And I think in our culture, so many things are compartmentalized, fractured, and siloed that we really have this generalized belief that things are not connected. We don't even believe we're connected to the earth, so we kill it, even though we need it to survive. That is the dissonance that we have in our human experience. We will cut down a tree, not even realizing that we need it for oxygen. When I began to realize that we think we're so separate from everything else externally, people also believe that internally we're separate. And so part of that psychoeducation and experience development is helping people realize it's all connected. That doesn't necessarily have to be causation, but there's definitely correlation and connection. There is nothing that's happening inside of your body that's not connected to something else inside of your body. So when the frustration of, I wanted to talk about this comes up, then my go-to is, and help me understand why that's important to you. Help me understand why. And by the time we get 3 or 4 down, they start to realize themselves that the situation isn't the issue. It's how they're processing the situation, how they're interpreting. And that takes us somewhere else. And so over time, people just usually develop a trust, not just in me, but themselves. I'll have people come in and be like, this is what I thought I wanted to talk about, but what's coming up for me now. And I love that because the process that we're working through ultimately is establishing their self-trust. Many of us have been outsourcing our trust since we were born. And as babies and children, we didn't have a choice. But ideally, when people are helping us to grow, they're not just meeting our need, but they're helping us to meet them ourselves. When that doesn't happen, we only know how to put our trust in someone else. And when that someone else is no longer available or we lose trust in them, we only know how to outsource trust. So we find something else to put our trust in. And there is no shortage of things in this world that is vying for our trust. So it's my personal parenting philosophy. And when I'm working with people one-on-one and in groups, I need you to trust you more than you trust me. Because I will not always be a source for you to get that validation. How do you learn to trust yourself? And I'm the safe place for when that trust led you somewhere you ain't want to be. And then it hurt. You get to come back here and we get to wipe up the wound and we get to be with the pain and we get to try again. But that's why I don't, friends, even my children, I don't tell them what to do. I help them negotiate it. And that's where a lot of folks don't go like, I wanted to go over here. They start to go a little bit deeper and go, I'm fixating on this, but it's all connected.
There's so much more to be said here because as soon as you said that, my brain went straight to like Eastern medicine and Eastern tradition and philosophy and connectedness, which I think is important to acknowledge that it's potentially so different than how your run-of-the-mill allopathic American practitioner has been trained. And even our medical system says, well, it's a brain thing, you go to neurology. It's a heart thing, go to cardiology. And it makes sense why we separate it out. But yeah, it's certainly this finding in therapy that it's like, these are not isolated things. I mean, look at EMDR. It's just this constant connection of concepts to get to something else to kind of, I call it minesweepering. If any of you remember Minesweeper, you play that dinky little game on your computer back in the day, and you would hit on like one field and it would pop open all these other fields and you're like, I just made 80 points. Like it's that idea that sometimes we click on something and it opens up so much more. And therein lies exactly what your point, I think, has been, is about reflection and the opportunity to kind of safely explore within that space and facilitate that for our clients.
And we don't have to do it all at one time. I hear you reflecting what I said. And I just, I don't mean the reflection then means we got to put this sense of urgency that we got to deal with it all at once. I just want people to understand that most people are not seeing the full landscape of what's in front of them in everyday life and within themselves. And a reflection can be as beautiful as a picture of nature that allows people to see that it's more than just a tree or a leaf in this picture. There's so much, and we can behold it and its beauty because we are able to see it all, not just hone in so tightly on one thing. And that opening for people is some of the greatest gifts they'll ever receive because no one's ever given it to them before.
Well, Shanda, it is always so lovely to have you. For listeners who are wanting to learn more about you and your work, what's the best way to do that?
You can find me at my website, www.thelaborsoflove.com. And also you can check out the Labors of Love podcast on all your streaming platforms.
Thank you so much, LaShanda. It's been wonderful to have you. I really appreciate you coming on and bringing so much transparency and applicability to our conversation today.
Beth, it is always an honor to join you, and I'm just so happy to be here with you. Thank you for having me back.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our one-year membership, where you'll have access to our growing library of Continuing Ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.